I want to thank all of y'all for coming to listen to my discussion on medication and your genes. First, let you know that I'm not an expert at this at all. This is a copy of my genetics textbook from my medical school. It's a paperback. It was 394 pages total, genetic information. This actually is a version that I found that's actually the version younger than mine, so mine was actually even a little bit smaller than that. I want to say I'm not an expert at this, but I wanted to give you some patient experiences so you can see what it is, how you can use the information that you get from this genetic testing. So we start back to when did genetics become a more powerful, more important thing, and really it sort of goes back to the Human Genome Project. That was a project that was looking at completing an entire one genome of a human being. And it was a collaborative international group that got together. It took 13 years for them to get it done, and so it was quite an undertaking. They looked at 3 million base pairs, over 20,000 genes, and it was actually a bargain. It came in at $2.7 billion, which was $3 billion was actually budgeted for it. They came under budget and actually under time in getting it done. You will hear patients talk about whole genome sequencing, and I want to contrast that to what I really want to talk about. So, because you're going to get that request from patients, I want to get them a whole genome looked at, and that can be done. It's possible to do it for the individual. It takes a few weeks. We're moving from what's called RT-PCR to next-gen technology, which is faster and quicker. Actually, Genopath's using the same technology for the stuff we're going to talk about in a little bit. Cost is anywhere from $2,800 to $6,000, but we expect that probably the price will drop to less than $1,000. And if you think about that just from a standpoint of $2.7 billion in 2003 to now, you're looking at over just a 12-year period going less than $1,000. The problem with it is, what do you do with the information? And from that aspect, I talked about a vendor that came to see me who wanted me to do genetic testing looking at cancer markers in patients. He said I can do 30 cancer markers, like breast cancer, pancreatic cancer, ovarian cancer, colon cancer. But my question to him was, okay, you tell me someone's got a 32.5% increased risk for pancreatic cancer. What am I supposed to do with that information? I can't do serial CAT scans every 6 months on someone for a cancer that's rare, hard to find, it's asymptomatic until it kills you. So I don't know what I would do with that information. And so I think a lot of times what we have with a whole genome is we've got a lot of information that we don't really have the screening techniques or the information we need to be able to care for the patient. And so I don't know that we're there yet. Now I will tell you, Hudson Alpha's doing whole genome sequencing. They've got a clinic and they're doing all sorts of things looking at like childhood diseases that are rare. And I think in that aspect it's probably a very powerful thing. But for right now, what can you use it clinically? And I don't think that there's a lot of applications for whole genome sequencing yet. However, pharmacogenomics, I think, is something you can use right now. It's a useful technology. The Human Genome Project identified 57 genes coding the cytochrome P450 enzyme. We know that that enzyme system accounts for about 75% of total drug metabolism, and that most drugs undergo deactivation, metabolism, by this enzyme system. However, there are several drugs that are bioactivated by the cytochrome P450 system. When we talk about the concept of personalized medicine, and that's really what we're sort of moving toward in using genetics, we know that of the 75% of medicines go through the cytochrome P450, about 80% of them go through about 5 pathways. And it's interesting that these are the pathways that we can see the genetic abnormalities in. One of the things I struggled with when I was learning this was the nomenclature, the terminology. It's hard until you kind of get an idea of what you're talking about. So, there are basically the 5 enzymes are 2C9, 2C19, 2D6, 3A4, and 3A5. There are, like I said, 57 different ones, but these are the ones that really are the ones that we're going to talk about that have genetic mutations. And what we're talking about in those genetic mutations is actually a single nucleotide polymorphism, a single base pair that's been substituted out in a person's genetic makeup that exists for these genetic mutations. So the term drug-gene interaction, talking about how someone metabolizes a particular drug, different than a drug-drug interaction, because you're talking about how a person, when they take that medication, how it affects them. And we know that adverse drug reactions are a major source for hospitalizations and deaths and costs in the United States. Those include drug-drug interactions. dispensing errors, inappropriate prescribing, administrative errors. But you can put on that as well a drug-gene interaction. You prescribe an appropriate dose for of medication to a patient. You give that appropriate dose of medication to a patient, and they have an adverse reaction that's related to the way that they metabolize it. That is an adverse drug reaction, and it may be one that's unpredictable because you don't know what their genetic makeup is. 2D6 metabolizes about 25% of all prescription drugs. The group that is probably one of the most important are the painkillers, and I say that to patients when I'm talking to them because you may never take a blood pressure medicine, you may never take a diabetes medicine, but there's a good chance somewhere in your lifetime that you're going to have a root canal or an appendectomy or a broken ankle or a reason to take one of the narcotics, and they're metabolized through 2D6. They're prodrugs. And so an example, hydrocodone or Norco that we prescribe goes through 2D6 and becomes hydromorphone, which is also known as Dilaudid, a much more powerful medication. Codeine goes through 2D6, is actually transformed into morphine. And we know that the 2D6 gene exists in more than 160 different versions. So the likelihood of there being an abnormality there is relatively high. So I like to talk to my patients when I'm talking to them about these metabolisms using animals. And I just find it's a lot easier to understand. A lot of you are wondering that we're talking about genetic mutations, and you wonder if this snail down here, has been genetically modified to become as large as the woman. That just was the way it ended up being. When I tell the patients, I get a report back and I say, okay, this is how this works. A normal metabolizer, and that's the people here, are people that would, if you give them a medication, they behave the way you'd expect them to behave with that medication. So the example I give them is you take a couple of Tylenol for a headache gets better in about 30 minutes or so, the medication's out of your system in 4 to 6 hours. It's what you'd expect how it can be metabolized. On the upper end of the spectrum are ultra-rapid metabolizers, it's indicated by the cheetah, and these are people that chew the medicine up very, very quickly. The example I give them is that if you have a sunburn and you put on a cream for the sunburn and you wipe it right off, there's no way for that medication to actually be as effective as it could be. Or it could be the other side, that is, it's metabolized very quickly from a prodrug, and you get an overdose because this stuff gets in your system too quickly. So on the bottom end of the spectrum with our mutant snail down here are poor metabolizers. And a poor metabolizer, the example I give, especially I tell them there's a lady and a man in the same room, husband and wife, I say, the guy won't understand this, but the lady will understand is you mix up a cake batter and you put it in the oven at 100 degrees for a half an hour, you get nothing. Nothing's going to happen. It's not hot enough. It's not going to give you what you're expecting to come out at the end with a cake. So those medications will not only not be effective, but they may linger around, give you more side effects, and cause you to have more troubles. And in between these are intermediate metabolizers and rapid metabolizers, which we indicate by the hare and the tortoise. And the idea there is that you don't have normal metabolism. It's maybe slightly slower or slightly more rapid than normal. But a lot of the times those patients will tolerate those medications, and it may just be a dosing adjustment that you have to make. So, and I give patients a copy of this scale so that they can kind of understand that. And I even refer to them as, you're a tortoise, you're an intermediate metabolizer, you're a snail, you're a poor metabolizer, and they seem to understand that. So, codeine metabolism in children. Codeine goes through 2D6, turns into morphine. If you're a poor metabolizer, there's our friend the snail again. It's ineffective metabolism to morphine, and they don't get pain relief. If you're an ultra-rapid metabolizer, the cheetah, rapid metabolism to morphine, you can have a rapid overdose. And so it's actually recommended that children not take codeine. And the big reason for that is because we don't know if they have a genetic mutation that might actually cause them to overdose, even though you give them a standard dose of medication. So that's the recommendation. So just talk about a couple of patients, and these are real patients that came to me. In fact, this is the patient that convinced me that I needed to start doing genetic testing in pharmacogenomics. 67-year-old female with a history of breast cancer, hypertension, reflux, and hypercholesterolemia. She's had a 6 months of a non-productive cough with some dyspnea. We treated her for allergies, we treated her for bronchitis, gave her steroids, gave her nebulizers or inhalers. Didn't get any relief. So I noted she was wheezing. I said, well, maybe you got some intrinsic asthma that was undiagnosed or you developed. We'll send you to the pulmonologist. We did pulmonary function tests, and they were normal, including a methylcholine challenge, so she didn't have asthma. So you're puzzled thinking, why is this lady having troubles? She's on Nexium for her reflux. She's on Norvasc for the blood pressure. She's on Zocor for her cholesterol. So we did her genetic testing, and this is what came up. Her 2C9 is normal, but she is an ultra-rapid metabolizer at 2C19. And she is also a poor metabolizer at 3A5. I tell patients that these two, as long as one of these is correct, for the most part, there's a lot of overlay and affected quite as much. So because she's an ultra-rapid metabolizer at 2C19, we know Nexium goes through 2C19. And although Nexium is an appropriate medication for reflux, I didn't think that poorly controlled reflux would be the cause for her wheezing. That didn't even cross my mind. She later comes in wheezing. I'm thinking of everything else in the world because I'm thinking, well, she's already on Nexium. It can't be that because we know it's a very powerful medication that should affect her reflux. But in fact, when I changed her after I got this information to 80 milligrams a day, it solved the problem. She no longer had any wheezing because I actually treated her reflux effectively based on this information. So, and we know in people who are ultra rapid metabolizers, they may need 200 up to 400% higher doses of proton pump inhibitors to get the effect that you want. She also happened to be on Norvasc and Zocor together. She is a normal metabolizer at both of these, at this enzyme and both of those medications, but they compete for metabolism. So taking amlodipine, it's an inhibitor of 3A4, and if you take those two together, increases the simvastatin levels and increases the risk for rhabdomyolysis, even though she has normal metabolism. It's a drug-drug interaction, not a drug-gene interaction, but it's related to where it competes in the genes. So pharmacodynamics, we talk about many drugs can increase or decrease activity of the cytochrome P450 system. Some of them induce, actually cause the isoenzyme to be more effective. Some of them are inhibitors and inhibit cytochrome P450 activity. And they're a major source of adverse drug reactions. And the example that I give you is Benadryl. 2 years ago, I would have told you that every little old lady that had sleep problems, take Benadryl, 25 milligrams. It's over the counter, it's cheap, it's easy to get, doesn't require a prescription. It may make you a little groggy the next day, but just take it a little earlier in the evening. And found out that it's a very powerful 2D6 inhibitor, and that medications that go through that pathway, it can cause problems with. So again, hydrocodone, oxycodone, 2D6 substrates, it can cause that not to be effective. And so as a result, I've stopped using Benadryl, especially in my elderly population, because of its interaction with other medications. Second case, 56-year-old female, history of diabetes, obesity, elevated cholesterol. She's got coronary disease. She's had a PTCA, depression, chronic back pain. Probably half your patients look like this in your practice. Depression's been poorly controlled. She's been on Lexapro for about 3 months. She's had fatigue. She's had some dizziness and it's been worse with standing, and her pain has been poorly controlled. Her medicine, she's on Lexapro, 2C19. She's on Plavix, which is 2C19. Coreg, which uses both 2C9 and 2D6, and Norco, which is 2D6. Metformin doesn't go through any of these pathways, and then simvastatin. Did her genetic testing, found out she's a poor metabolizer both at 2C9 and 2C19, and an intermediate metabolizer, or a tortoise at 2D6, normal metabolism at the other two. So made some changes just based on her genetic makeup, knowing that she's 2C19, metabolism is not correct. I switched her from Lexapro to Vibrid, which uses 3A4. I switched her from Plavix to Effient because it's 2C19. Plavix would not be an effective drug for her. And I also switched her from Coreg to atenolol. Even though Coreg has sort of a dual metabolism, I knew she was a poor metabolizer at 2C9, and atenolol is renally metabolized. It's not affected by any of her genetics at all. And after 3 weeks on new medications, she was better. Depression was improved, fatigue was improved, her dizziness had improved, and so the question is, was she actually having some postural hypotension from the Coreg that she wasn't metabolizing? It was staying around in her system. It's certainly a possibility. So in summary, personalized medicine, pharmacogenomics allows for a customized approach to patients based on specific genetic mutations. I often tell patients that before I had this tool available to me, it was all trial and error. If somebody came to me and they were depressed, I would say, okay, let's try you on Lexapro. And the reason I would pick Lexapro is because generally most people tolerate it. It's usually an effective medication. And so it's like I was walking up to a set of doors and I was having to pick a door based on my experience that I thought was the right path. With pharmacogenomics, they're glass doors. You can see through them. You can see, okay, this is not a good choice for this patient. I shouldn't even go that way because I know they're not going to do well with that medication. Also, it's not going to to change. It's that person's genes and can be used for the future. And that's for current medications, making adjustments is important, but also for future medications. And so I encourage all my patients to take this information to their specialist so that they can talk to them about the medications that they're on. It also empowers the patients. You'd be amazed at how happy they are to have this information in their hands. They're able to look at it and say, this is me, I'm unique, different from everybody else. Everybody likes to be unique, we know that. And there's also cost savings. You don't have to do as much trial and error because you can look at a medication and go, okay, I know this is not going to work, I need to go to something different. And we talked about before, doubling up on someone's PPI. Most insurance companies won't pay for that, but if you have a genetic basis for that, you can actually use it for a prior authorization. So this is a copy of my mother's tonsillectomy from 1932. You see the date up here was 8/3/1932. This is her bill. She had operating room services, 1 day stay, she was $2. Operating room service was $3. She had 25 cents worth of medicine and 25 cents worth of dressings. Her total bill was $5.50. So we've come a ways since 1932 in the cost of medications. And I think a couple of things that are interesting on this bill, it says all bills are payable weekly and accounts must be settled before the patient leaves the hospital. This is necessary as there's no